So we are gonna start with vitamin C deficiency. Vitamin C deficiency is also termed as scurvy, and it has some hallmark manifestations that you guys need to keep in mind. So let's first discuss what causes vitamin C, what happens during vitamin C deficiency. What happens is basically the synthesis, collagen synthesis is impaired, that is, connective tissue synthesis is disturbed, as a result of which we get the following manifestations. Coiled hair, perifollicular hemorrhage. Why do we get coiled hair? We get coiled hair because during the proliferation of keratinocytes, you guys can read it as well, vitamin C is required. So the hair strand that is produced is inadequate, as a result of which its appearance is a little bit different. So perifollicular hemorrhage, as the hair shafts come out of the skin surface due to improper synthesis of the connective tissue and the collagen in the skin, that results in rupture of the blood vessels, resulting in hemorrhage around the follicular area. I'll show you guys these two manifestations. So as you guys can see here, the corkscrew hair and the perifollicular hemorrhage. So if you just focus here, you can see that all the places from where the hair shaft is originating, you get a hemorrhage from that area. The reason I've told you it's because of deficient collagen and connective tissue in the skin that results in rupture of the blood vessels as the hair shaft comes out. And you can see that the hair is also really curved and not coming out straightly. This is termed as corkscrew hair. So the mucosal findings would be inflammation of the gingiva and accompanied with bleeding. So this is the most common known manifestation of scurvy that everybody is aware of: bleeding from the gums and swelling in the gums as well. But it's not necessary that you always present with this presentation. Usually, the most common presentation, ironically, is just pain in the joints and due to periosteal hemorrhage. Why does the periosteal hemorrhage happen? Same deficiency and inadequate connective tissue. And since the periosteum is also a form of connective tissue, hemorrhage can occur due to fragility of the blood vessels in the periosteum, that can result in a limp while walking and joint pains as well. So other ones include depression, vasomotor instability. So what's the most important thing I would like to point out here is that the question they gave, which I got incorrect, was the following, where the manifestations were just arthralgia, limp, depression, and vasomotor instability, and the diet was mentioned as well. So one of the most important ways you'll be able to diagnose is by the diet. Really common in chronic alcoholics because of nutritional deficiency, in severely malnourished individuals such as anorexia, and insufficient dietary intakes. Usually a child who does not like to eat fruits, alcoholic, or a person with anorexia is gonna present. You need to keep the demographic in mind in order to catch the diagnosis. So you also get anemia in the CBC. Why do you get anemia? The reason behind anemia is that vitamin C, when ingested, results in the conversion of iron from Fe plus 3 to Fe plus 2. That is the form that is absorbable by the gut lining. So inadequate intake of vitamin C uh, basically indirectly results in inadequate absorption of iron from the gastrointestinal tract. That is why you get a typical iron deficiency anemia, that is normocytic and microcytic or and hypochromic. So it's basically just an iron deficiency anemia that is happening because vitamin C is not present, that is affecting the absorption of iron. So the most important thing, you keep the demographic and you keep these symptoms, and you know that it also causes iron deficiency anemia. So treatment is just, the most important treatment is injectable vitamin C, which leads to rapid improvement. You can also use oral as well. So let's come on to this high yield table, and I'll point out all the questions that come from this high yield table as well. So we're gonna start. Let's just get off the vitamin C, termed as ascorbic acid. We just did it right now that it causes scurvy, hallmark finding, joint pains, bone pain, and perifollicular hemorrhage, and really weird looking hairs. And the demographic would be anorexic patient, an alcoholic, or a child who does not like to eat fruits. So this is vitamin C, and let's come on to thiamine as well. As you guys know, Wernicke-Korsakoff syndrome, and the symptoms are really made really well, memorized really well if you remember the uh, uh, if you remember, I'll just write it down. If you remember that mnemonic, that is a cow. A stands for ataxia, and a cow. So A stands for ataxia, C stands for confusion or confabulation, O stands for ophthalmoplegia, which is basically you're gonna get nystagmus, and W stands for Wernicke. So it helps to identify the reason and all the symptoms that you get in Wernicke and Korsakoff. What is meant by Korsakoff? So the Wernicke is basically an acute phase, Korsakoff is chronic. So Wernicke, as I told you about the mnemonic, A, cow. So A, ataxia, C for confusion, O for ophthalmoplegia, that is basically ophthalmoplegia, plegia means ataxia, and W stands for Wernicke. So what happens if this is the acute phase where you get these three symptoms, and if you give thiamine, the patient gets better. If the deficiency goes chronic, you get also Korsakoff syndrome. It's basically everything you get in Wernicke plus Korsakoff, that is chronic loss of memory, inability to form new memories, where you get confabulation as well. What is confabulation? Confabulation means that the patient does not remember what happened, so the patient just makes up things in order to fill in the gaps of what happened. So the most important demographic is that you need to remember alcoholic would be there, and the most important question that you need to remember is that in order to correct the deficiency when a person presents with Wernicke, you do not directly give glucose, because the patient is usually an alcoholic, and if you do a blood glucose that would be the BSR would be low. So do not give glucose. First give thiamine and then give glucose, because glucose metabolism requires thiamine. And if you just give glucose first, the deficiency is gonna get even more worse. So basically, the question is gonna be that the patient that is an alcoholic presents with the symptoms of has ataxia and nystagmus in the eye, and you should know that it's due to thiamine deficiency. What is the next best step? Do not, you'll get, they'll also give you a BSR of the patient where the patient's glucose is at 30 or 40 and ask you what is the next best step. So you go for thiamine infusion first and then glucose followed by thiamine infusion. Never give glucose first when you suspect thiamine deficiency. So let's move on to riboflavin. So the most high yield finding here is you're gonna get seborrheic dermatitis. What is seborrheic dermatitis? You basically get seborrheic dermatitis in places where hair is grown. Like you can get it here in the eyebrows, you can get it in the scalp, you can get it behind the ears, and you basically get overgrowing fungi and you form yellow flakes and the scalp becomes red and itchy. I'll show you a diagram. So this is the most high yield presentation. You get it in the scalp. You can also get it in the eyebrows, behind the ears, on the face, but the most high yield place is the scalp. So you get these, the scalp becomes red. You get these yellow plaques forming, and the scalp also is itchy. So what is and one more high yield thing about seborrheic dermatitis is that it is associated with Parkinson's disease. So the people with Parkinson's disease and they give you this presentation and ask you for a diagnosis, or you should go for seborrheic dermatitis. And even if they just tell you Parkinson's disease and they ask you what is the most likely disease that this patient is prone to developing, skin condition, you go for seborrheic dermatitis in that case as well. So you just B2 deficiency, seborrheic dermatitis, Parkinson's disease, seborrheic dermatitis. This is a skin condition. You guys need to remember these two high yield associations. Now let's move to niacin, vitamin B3. Just remember the three Ds. That is dermatitis, diarrhea, dementia. That is pellagra. Basically, with deficiency of B3 causes pellagra. And one more high yield, the most high yield question you get here is that a patient has carcinoid syndrome where the patient is producing excessive amounts of serotonin, and that patient has dermatitis, diarrhea. What is the most high yield or likely vitamin deficiency in this patient? The answer is going to be niacin. Why? Because niacin is used during the production of serotonin. So if you get a cancer like a carcinoid syndrome where excessive amounts of serotonin are being produced, niacin would be quickly used in the body. You get all the niacin would be used up in the body, and then you'll get niacin deficiency and develop pellagra as well. So the dermatitis is basically high yield. They say the dermatitis occurs in the sun exposed area, so it's like a necklace rash. It has a special term for it. So it's the dermatitis here. This is not seborrheic dermatitis, the one which occurs in pellagra. It's just a dermatitis in the sun exposed areas like the neck. And it's basically dark in color. I'll also show you a diagram. You get diarrhea, you get dementia. Dementia is just memory loss and symptoms of depression. So the most two high yield things about niacin is a person who is on a diet that is corn based, and a person who has carcinoid syndrome where excessive amounts of niacin are being used. So you get pellagra in these two cases. So you just need to remember these two: corn diet and carcinoid syndrome where excessive amounts of serotonin is being produced. So this is the rash I was talking about in the sun exposed areas. So you can see the hands, and the consistency of the rash is it is hyperpigmented and scaly. You just need to remember these two terms: hyperpigmented and scaly in the sun exposed areas. So this is the dermatitis rash of pellagra. So we're also done with niacin as well. So one more thing I need you guys to remember is that vitamin B2 and B6, 2 and 6 cause angular chillosis. Both of these cause angular chillosis, stomatitis and glossitis. So B2 and 6, you can link up all these symptoms and know that B2 and B6 have some overlapping symptoms such as angular chillosis, stomatitis and glossitis. So seborrheic dermatitis is going to help you differentiate and tell you that it is B2, and when it comes to B6, you're gonna get that symptoms of irritability, confusion and depression in addition to these three. Basically you're gonna be looking for seborrheic dermatitis to differentiate between these two. So let's come to pyridoxine. The most high yield question when it comes to pyridoxine is a TB patient who is taking isoniazid, and that patient develops one of these symptoms. Mainly they're gonna say that the patient has developed fissures around the angle of the mouth. That this is termed as fissures around the angle of the mouth, means angular chillosis. Angular chillosis in a patient of being treated for TB, you go for which deficiency? Pyridoxine deficiency, that is B6. So usually whenever we treat a patient with isoniazid, we also give pyridoxine in order to prevent the deficiency. So this is the most high yield question when it comes to vitamin B6. So let's move on to vitamin B9, that is folic acid. The deficiency causes megaloblastic anemia, and deficiency of vitamin B12 also causes megaloblastic anemia. And one more thing, folate deficiency occurs quickly, whereas when it comes to vitamin B12 deficiency, it takes years to develop because the stores in the body of vitamin B12 are really high. it is stored in the liver, and the liver stores a large amount of B12. But when it comes to folate, you can get deficient really quickly. And which demographic of people gets deficient? Who does not eat green leafy vegetables. Whenever it comes to folic acid, I remember the source means the sources of folic acid are basically green leafy vegetables, and that is how I know that spinach contains folic acid. You can take fortified cereals. So basically, folic acid deficiency, you've heard pregnant women require it because the deficiency during pregnancy, especially in the first trimester, can lead to neural tube defects and megaloblastic anemia in the person who has the deficiency. B12 also megaloblastic anemia, plus you get the severe combined subacute degeneration of the posterior column in the spinal cord, which presents as initial paresthesia in the lower limbs followed by loss of proprioception. So you get paresthesias followed by loss of proprioception. So they're going to say that the patient is losing his balance. They don't mention directly that there is loss of proprioception. They just say the patient cannot balance himself and has ataxia. So basically, paresthesia is followed by ataxia, that represents posterior column in the spinal cord is having some trouble, which means severe posterior column degeneration. The specific term is subacute combined degeneration of the spinal cord. So the patient is gonna say initially had uh, paresthesias. What the patient is gonna explain paresthesias like he had tingling sensation in his lower extremity and needle pricking sensation, and after that he had problems balancing himself, and that means ataxia. And if you do they're going to also tell you that the examination was performed if it's severe combined posterior column degeneration, subacute combined degeneration. You're going to get positive Romberg, which means since the patient has lost proprioception, if the patient closes his eyes, he just loses balance and falls. And the Babinski is also gonna be positive. Why? Because the dorsal column includes the upper motor neurons, so the Babinski in the lower extremity is gonna be positive as well. So this is more than enough to know about cobalamin, everything that you need to know. So let's just give it a read as well. Riboflavin, as I told you guys about B3 and B6, the triad is gonna be same for B3 and B6, that is angular cheilitis, glossitis, that is inflammation of the tongue, and stomatitis. That glossitis means inflammation of the tongue, stomatitis means inflammation of the mucous membrane, presents as sore throat. And they also talk about niacin deficiency that causes pellagra, 3Ds, dermatitis, diarrhea, dementia. Dermatitis would be hyperpigmented, scaly in sun exposed area. Dementia would be basically memory loss, depressed mood, or psychosis. And if the patient has serotonin carcinoid syndrome, then he can get pellagra. If the patient has corn based diet, then he can get pellagra. And if the patient has undergone gastric bypass, that also makes the patient prone to deficiencies. Like patients who undergo Roux and Y gastric bypass are a risk for multiple vitamin deficiencies, mainly fat soluble, because the acid from the gastric mucosa is required for the absorption later in the ileum. So the most common ones are vitamin B12 and vitamin C. Deficiencies seen in gastric bypass. B12 deficiency and vitamin C. Other can also occur. So these are some high yield points. The same patient being treated for TB and has fissures around the corners of the mouth, that is pyridoxine deficiency, and the patient should receive pyridoxine supplementation along with INH, that is isoniazid. Another question, high yield one, patient complains of episodic wheezing and flushing of face, now also has a diastolic heart murmur at the left fourth intercostal space. So it's diastolic, it's at the left fourth intercostal space. most likely APT. It's at the T region and it's diastolic to tricuspid recurge, most likely. Now has symptoms of depression and a hyperpigmented rash on the face and neck that is scaly. Which vitamin deficiency is likely here? So we have carcinoid syndrome resulting in a niacin deficiency. So, and that is why the patient is having dermatitis and depression. And the murmur is because excessive production of serotonin from the tumor results in calcification of the tricuspid valve. So this is basically carcinoid syndrome that has metastasized to the liver and now is causing symptoms. Uh, since systemically the serotonin can be released when it metastasizes to the liver. As long as it stays in the gastrointestinal tract, there are no symptoms. But when it metastasizes to the liver, it bypasses the first pass effect and serotonin is no longer degraded by the liver. It directly goes into the systemic circulation. So you now start having symptoms. And the vitamin deficiency associated with carcinoid syndrome is niacin. Enteral nutrition. So what is enteral nutrition? Enteral nutrition means nutrition through the mouth, and parenteral nutrition means nutrition given through the intravenous route. So enteral nutrition is the most likely optimal form of nutrition for severe burn injuries. So it's a little bit, it can be counterintuitive, as you can say that the patient has burn injuries, the patient cannot eat, but still the most optimal form of nutrition is enteral nutrition. Should start enteral nutrition within 24 hours. So what are the benefits? They also tell the benefits. The benefits include that maintenance of gut integrity. Gut is not just left like that. It once, if it is continually being used, so the integrity of the gut is maintained. Reduced rate of sepsis, decreased mortality. So basically it's a research oriented decision that enteral nutrition, if started earlier, results in decreased mortality in patients with severe burn. Basically, it just helps offset the hypermetabolic response after burns and has multiple clinical benefits that have been deciphered through research. So the question most commonly asked is, they'll give you a burn patient and say that the patient has mucosal burns and a lot of other stuff as well, third degree burns, and they are gonna ask which is the next best step when it comes to providing nutrition to the patient, and they'll give you parenteral nutrition, they'll give you enteral nutrition, they'll give you start or switch to enteral nutrition within 24 hours. So you select the one that says start enteral nutrition within 24 hours. At the moment you can just give IV fluids and everything else, but you'll have to start within 24 hours. So we're gonna start vegan diet now. So most important thing you need to know about vegan diet is what deficiencies can you expect in a person who's a vegetarian. So basically the most common ones are vitamin D, calcium, and vitamin B12. Vitamin D is a fat soluble vitamin. It is usually found in animal fats such as fish oils. When it comes to calcium, calcium is usually found in animal derived protein sources such as milk and meat as well. Same goes for iron as well, but it is possible deficiency since iron is present in myoglobin when animal meat is consumed. When it comes to vitamin B12, this is also found in meat as well. So the most common deficiencies include calcium, vitamin D, B12, and iron. Iron is usually might not be deficient since the deficiency is under it's usually covered up through other sources of iron such as vegetables. But when it comes to women, young women who are undergoing menstrual blood loss monthly, it can be exacerbated in such conditions. So here it is mentioned that menstrual blood loss requires higher iron in order to replete the iron store. So in such a case, in such a demographic, the iron deficiency may also become prominent if the person consumes vegan diet. So the questions they usually come up as they'll explain that the person is vegan, and then they might give you one of these vitamins and ask you which one might be deficient in this case of a person who is a vegan, such as vitamin D, calcium, B12. They can give you a vegan person who has bone pain and fatigue and symptoms of depression. And in that case, the answer can be vitamin D. And they can ask you what is the next best step. You can order a vitamin D level in the blood that would be 125 dihydroxycholecalciferol levels in the blood. Same it goes for a person who is vegan, has megaloblastic anemia. They'll ask you which of the following vitamins is most likely deficient in this space. In this case, it can be vitamin B12. You'll have to choose vitamin B12 in that case. They give you a vegan and give anemia microcytic. You choose iron. They give you a vegan and they tell you about the bone density in that person, which is reduced, and the answer can be vitamin D or calcium. So this is how the questions are gonna asked in this case. The main things you need to remember are what are the most common deficiencies present in person who is a vegan. That is it. So, so this table covers the trace mineral deficiencies. I'll just tell you about the most major ones and the high yield points. So you are supposed to remember the one-liners I'm gonna give you. Copper, subacute combined degeneration with sideroblastic anemia instead of megaloblastic anemia. It's gonna be copper in this case. Neurological dysfunctions like B12 deficiency, that is combined subacute combined degeneration, where initially the patient gets tingling sensation in the lower extremity followed by ataxia due to loss of proprioception. Romberg sign would be positive, Babinski would be positive as well. So this is going to be present in a patient along with sideroblastic anemia, in which you see ringed sideroblasts, on the smear. If you do a blood smear, you're gonna see a RBC with ringed sideroblast. I'll show you a diagram as well. So in this combination points towards copper deficiency. Iron deficiency, it's microcytic anemia, and the last high yield one is zinc. So zinc is really important for sexual function. Deficiency of zinc results in sexual dysfunction and impaired taste. So these two are the high yield ones. Uh, what you can remember is rash with impaired taste and sexual dysfunction, that is hypogonadism, it's going to be zinc. So let's cover it up again. Subacute combined degeneration with sideroblastic anemia, copper deficiency, uh, impaired taste with a rash and sexual dysfunction, it's gonna be zinc. So when are these trace mineral deficiencies gonna be apparent? Usually, since they are trace minerals, usually you do not get deficient unless you have a absorption problem or you are on parenteral nutrition. So the two demographics where you need to be aware of these trace mineral deficiencies include people who have bowel diseases, bowel resection, or are on parenteral nutrition for a prolonged amount of time. For example, bowel diseases like celiac, Crohn's, ulcerative colitis would not be included because it does not include the small bowel. Diseases that include the small bowel, such as celiac or and Crohn's disease that involve the ileum and jejunum. These diseases, along with parenteral nutrition, can lead to these trace mineral deficiencies. So the two important ones, copper, where you get subacute combined degeneration along with sideroblastic anemia, zinc, where you get sexual dysfunction, a rash, and impaired taste. So they've also written here that malabsorption, parenteral nutrition are the two most high yield causes of trace mineral deficiency. So these are the two important ones, copper and zinc, that you need to remember. Iron, you already know it causes microcytic anemia. Chromium makes it hard for diabetics to control their glucose levels. But you need to be wary of the demographic. Malabsorption disorders and parenteral nutrition can lead to these. So first, you confirm that if the demographic is of the patient demographic is appropriate, then you can go towards selecting which trace mineral deficiency the patient might be suffering from. So now let's start malabsorption syndromes. We'll start with celiac disease. So what is celiac disease? Celiac disease is basically an autoimmune disease where there is an autoimmune reaction against a food particle termed as gluten. Not directly towards gluten. The autoimmune response is directed not directly towards gluten, but it is directed towards gliadin, which is basically a byproduct of a gluten breakdown. Gluten is found in wheat and whole grain products. So it is broken down into gliadin, and in certain individuals they produce an autoimmune response to gliadin that results in destruction of the villi in the gastrointestinal tract, and as a result it results in malabsorption. So the most high things that you need to remember about celiac disease are which part of the small bowel is involved in celiac disease the most, and which part, biopsy of which part would be done in order to confirm celiac disease. You know, celiac disease has certain symptoms, but in order to confirm celiac disease, you need to perform a biopsy, and the biopsy would be performed of proximal jejunum. So this is also going to be asked in a question where they're going to give you a presentation of celiac disease and ask you what is the next best step. And they're going to give you options of biopsies: biopsy of duodenum, biopsy of proximal jejunum, biopsy of distal jejunum. You're going to select biopsy of proximal jejunum because that is where celiac disease can be identified. So moving on next, what are the risk factors? Just autoimmune disease. So, autoimmune diseases go with other autoimmune diseases. So, if a person has thyroiditis or thyroid disease, autoimmune thyroid disease, SLE, or other autoimmune diseases, you can most probably conclude that the patient can also have celiac disease. What are the symptoms, high yield symptoms? So what happens when the atrophy of the villi happens? Atrophy of the villi happens that results in malabsorption, and all the malabsorbed nutrients are then the bacteria acts on all those malabsorbed nutrients, and gas is produced that results in abdominal pain due to bloating and distension of the bowel. So you get abdominal pain, diarrhea. Obviously, why do you get diarrhea? You get osmotic diarrhea because all the nutrients are not absorbed, and those nutrients exert an osmotic effect and suck all the water from the mucosal lining of the bowel. That results in diarrhea. Distension because the bacteria degrade the unabsorbed nutrients and produce gas. Flatulence and bloating because gas is produced. So late manifestations, you need to just remember enteropathy associated T cell lymphoma. This is also termed as malt lymphoma. Malt means mucosal associated T cell lymphoma. Celiac disease is associated with malt lymphoma. So other symptoms of celiac disease include because depression and iron deficiency anemia. Why? Because iron is not absorbed properly, so it results in iron deficiency, anemia, and depression. Uh, it's not a direct byproduct of celiac disease. Uh, when it comes to depression, there are several different schools of thought. Some people say it's because of malabsorption of the nutrients, others say it's a direct effect of celiac disease. So the other two, other than the classic GI symptoms, you have uh, depression, and the other one that I mentioned was iron deficiency anemia. So we will just also read all the other ones. Uh, First, general, you're gonna have fatigue, weight loss, reduced stature in children. Why? Because it's a malabsorption disorder. You're not properly nourishing the body. Orally, you're gonna see uh, uh, inflammation of the tongue, because since it is a glossitis, what can be the reason behind this? Loss of a lot of vitamins such as vitamin B3 and B6. Their deficiency causes atrophic glossitis, so that can be a reason as well. The most high dermatologic finding that should be on your fingertips is dermatitis herpetiformis, which is a papulovesicular rash. What do you mean by a papulovesicular rash? So a papule is basically, this is the skin surface. So this is a papule. And what is a vesicle? Vesicle is a fluid filled outpouching from the skin surface. So you have, if this is the skin, you are gonna have papules and you're also gonna have vesicles. Vesicles are basically fluid filled outpouching from the skin surface. So you're gonna have both of these, and this is a high finding of celiac disease. So a patient with bloating, loss of failure to thrive, flat flatulence upon eating, and also has a rash that looks something like this. So the high yield area where you get dermatitis herpetiformis is on the extensor surfaces, like extensor surface. So first, let's just see what they mean by papulovesicular rash. So these are the vesicles that are fluid filled, and these are the papules. As you can see, the just slight outpouching from the skin, and this is outpouching with fluid filled structure. So these are vesicles, these are papules, and the dermatitis herpetiformis, the rash, it's really itchy and it contains vesicles and papules. So what is the pathophysiology behind this rash formation? So first of all, you guys need to remember, they can ask you another scenario and ask you what is the hypersensitivity reaction type in this case. So you're gonna say, they're gonna give you a patient where the classical symptoms of celiac disease, you're gonna know it's celiac disease. They're gonna give you the rash and then ask you what is the hypersensitivity type of this rash. It's going to be type 3 hypersensitivity. So let's just see what causes dermatitis herpetiformis. So basically, the person is hypersensitive to gluten. Gluten is turned into gliadin, and the body reacts to it and produces Ig antibodies. Those Ig antibodies form immune complexes that deposit in the dermal papillae of the extensor skin surfaces. It can be the other skin surfaces, but usually on the extensor skin surfaces, the Ig antibodies produced as a result of exposure to gliadin combine with the antigen, and these complexes then deposit in the dermal papillae, and the deposition results in the activation of the complement system, and the reaction then further proceeds, causing the inflammatory cascade and production of the papules and vesicles, itching, and all that stuff. So it's a type 3 hypersensitivity reaction, that is dermatitis herpetiformis. So they can also ask the question in terms of immunology, give you the finding and ask you the type, hypersensitivity type. So it's going to be type 3 hypersensitivity. So the iron deficiency anemia due to malabsorption, neuropsychiatric symptoms, depression. I told you the three high yield ones that we have: iron deficiency anemia, depression, and dermatitis herpetiformis. These are the most high yield ones. Musculoskeletal, you can get osteoporosis, you can get fatigue, joint pain, muscle aches due to vitamin D deficiency, as well as calcium malabsorption. Vitamin D deficiency, secondary hyperparathyroidism. Obviously, when you get a vitamin D deficiency due to malabsorption, the body is gonna compensate by increasing the parathyroid hormone to maintain calcium levels. So you're gonna get secondary hyperparathyroidism as well. But the main things are the ones that are highlighted in red. Type 3 hypersensitivity reaction, which is dermatitis herpetiformis. This is a high yield question. And if they ask you what hypersensitivity reaction is the celiac disease itself, it's a type 4 hypersensitivity reaction. These points should be on your fingertips. So the immune complex that deposits in the dermal papillae is the IgE antibodies produced against gliadin, plus the tissue transglutamase. We can also call it epidermal transglutamase. This is the antigen. So the meaning of telling you guys is this: it's not the direct antibody that deposits, it's the complex IgA plus epidermal transglutamase antigen. So these two combine and then deposit and cause the activation of the complement system, followed by everything else. So diagnosis is confirmed by increased tissue transglutamase and IgA antibodies. So where does this come from? So basically the enzyme tissue transglutamase is what converts gluten into gliadin, against which the antibody reaction is then produced by the body. So what you see the antibodies formed are against tissue transglutamase. This is what against which the antibodies are produced. So you measure the level of tissue transglutamase Ig antibodies in the body, and that confirms the diagnosis of celiac disease, as well as the final confirmation would be done by the biopsy, proximal intestinal biopsy, proximal jejunal biopsy. So what are you going to see upon a microscopic examination? You're going to see villus atrophy. Why? Because there is inflammation going on, crypt hyperplasia. Why do we get crypt hyperplasia? Because the cells of the villi are destroyed. So the crypts are the areas where a lot of mitotic activity is happening, and that mitotic activity replaces all the cells that die in the villi. So since the villi are constantly being destroyed, so there is hyperplasia in the crypt in order to replace those cells. Intraepithelial lymphocytosis. So if you see the cells, when it comes to celiac disease, the cells in the villi, like if this is the villi and these are all the cells, due to ongoing inflammatory reaction, you're gonna see, if you just microscopically examine, you're gonna see a lot of blue dots in the cells, a lot of blue dots, which are basically lymphocytes in the villi cells, in the epithelial cells of the villi. This is termed as intraepithelial lymphocytosis, which shows that an inflammatory reaction is ongoing. So these are the findings what you see, and you can also be questioned about these findings as well. Like they are gonna tell you upon histopath exam, you see villus atrophy, crypt hyperplasia, intraepithelial lymphocytosis, and they can keep the other symptoms vague, but just by reading the histopath findings, you can conclude that this likely is celiac disease, plus the location as well. It should be proximal jejunum. Peripheral neuropathy and atrophic glossitis usually occurs before GI symptoms occur. Affected proximal jejunum. This is a high yield. That's why I just stressed it again and again. So treatment, Apsone is used for the treatment of dermatitis herpetiformis, and obviously since the celiac disease itself, it's a hypersensitivity reaction, you remove the antigen, that is, you revert to a gluten-free diet. So, features of malabsorption in celiac. General, since it's bulky, foul-smelling, floating stools, because a lot malabsorption, all the malabsorption disorders are gonna give you this finding of bulky, foul-smelling, floating stools. Like for example, in chronic pancreatitis, where you get pancreatic insufficiency, you're gonna get the same thing. And if in certain individuals who are trying to lose weight using drugs that reduce the absorption of fat, such as we are talking about orlistat, it causes inhibition of pancreatic lipase, and that results in malabsorption. So you get the same symptoms. Basically, what I'm trying to hammer in is that in case of all malabsorption disorders, you're gonna get the same bulky, foul smelling, floating stools. Fat and protein loss of muscle mass, iron, anemia and malabsorption की वजह से calcium and vitamin D. Obviously, vitamin D is a fat soluble vitamin, so malabsorption disorders also result in vitamin D deficiency. Vitamin K and A are also fat soluble, so you're gonna get easy bruising. Why? Because vitamin K deficiency results in lower production of the clotting factors, so that results in easy bruising. Vitamin A, and since the clotting factors are reduced, you're gonna get an increase in PT and APTT both, because a reduction in vitamin K results in reduced production of all the clotting factors. So vitamin A, you're gonna get hyperkeratosis, that is corneal cells get multiply faster, and that results in excessive production of keratin by the keratinocytes. I'm at the moment I'm talking about the skin. So get excessive production of keratin in the stratum corneum of the skin, since the epithelial cells are now misprogrammed. Basically, vitamin A helps the epithelial cells to properly differentiate, and its deficiency results in like a misprogrammed keratinization, excessive keratinization of the skin, that results in thickening of the skin and callus formation. You get thickened skin. Basically, the epithelial cells of the skin go AWOL when it comes to vitamin A deficiency. So, uh, the antibody that you're gonna be able to find is anti-tissue transglutamase IgA antibody, that is gonna confirm. So, if IgA serology is negative, so in a person who is IgA deficient, in that case you won't be able to find the positive anti-trans tissue glutamase antibody. So in order to further confirm, you need to measure the total IgA level in order to make sure that you have ruled in or out this disease. High suspicion for celiac, negative anti-tissue transglutamase antibody. What is the next step? Total IgA levels in the blood. So this is what I wanted to say, that in a person who is IgA deficient, you are not going to be able to find this antibody. So the next best step would be to measure total IgA antibody. So we're gonna start with the D-xylose test. Usually, when they give a D-xylose test, they ask you to interpret the results. They'll just give you the stats and the results of the test, and then ask you to interpret it. So what is D-xylose test? You basically just give, it's a monosaccharide D-xylose. You just give it orally, and then you check after a certain amount of time. You check the levels of this D-xylose, that is a monosaccharide, in the blood and in the urine. If it is absorbed adequately, you are gonna see high levels in the blood and the urine, and if it is not absorbed, you're gonna see low levels. So let's just talk about the interpretation. So since it is a monosaccharide, it does not require breakdown by the enzymes. It's directly absorbed through the gastrointestinal tract in the jejunum and the absorptive areas of the ileum. So what are the conditions where it might not be absorbed? The first condition that comes to mind is malabsorption due to mucosal disease like celiac disease, where there is atrophy of the villi, so D-xylose would not be absorbed in that case. Another example would be a small bowel in a bacterial overgrowth, in which case the D-xylose, before it gets a chance to get absorbed, it would be degraded by the bacterial overgrowth in the small bowel, and since it's going to be degraded, it won't get absorbed. And in case there is malabsorption due to pancreatic enzyme deficiency, in that case these xylose would be absorbed. But you guys see why it would be absorbed, because it's a monosaccharide, it does not require enzyme breakdown prior to getting absorbed. So basically, D-xylose test helps differentiate between malabsorption. So first you have a patient with malabsorption disorders, then you perform a D-xylose test, and it's going to tell you whether the malabsorption, that is steatorrhea and the diarrhea, is either due to mucosal disease or an enzyme deficiency. mucosal disease like celiac disease, enzyme deficiency like chronic pancreatitis leading to pancreatic enzyme insufficiency. So in case of celiac disease, you would get low levels, you would get negative D xylose. And what does negative D xylose means? Adequate D xylose levels detected in the urine and the serum. This is termed as negative. So interpretation is also important. By you should know what a positive means and what a negative test means. A negative test means that D-xylose has normally been absorbed, whereas a positive D-xylose means there is an abnormality in absorption. So the negative means that there is adequate absorption, positive means that there is an abnormality. So, the scenario is just like you get a patient with malabsorption, they perform a D-xylose test, and then they tell you that the D-xylose test is positive. You should already know what positive means. Positive means that low levels have been detected. So, and they give you an option of diagnosing what the patient has. They'll give you celiac disease, they'll give you chronic pancreatic insufficiency. So a positive D-xylose means that D-xylose has not been absorbed. So it is not due to enzyme deficiency, it's due to mucosal disease like celiac disease. Because if it were enzyme deficiency, D-xylose test would be negative because D-xylose does not require enzymes to get absorbed. It's already a monosaccharide. So this is how the interpretation comes into play. So it's normal D-xylose and abnormal. What is a normal D-xylose? Normal D-xylose means adequate levels have been detected systemically and absorption is good. So a normal D-xylose test means negative D-xylose test. That is what I want to hammer in. That a negative means a normal D-xylose and a positive means an abnormal where low levels have been detected. So normal absorption happens if there is the pancreatic insufficiency and the mucosal lining is just fine. Abnormal happens when there is mucosal issue, that is celiac disease, D-xylose is not absorbed, small bowel bacterial overgrowth, in which case the D-xylose is degraded before it gets a chance to get absorbed, or in case of gastroparesis, in which case the D-xylose test after it is usually performed 2 hours after ingestion. So if a person has gastroparesis, the D-xylose would not move forward and you would get a false abnormal or a false positive D-xylose. So this is all what you guys need to know. A false positive occurs in small intestinal bacterial overgrowth because mucosalizing lining is just fine, but the bacteria just degrade it. So you get a false positive. If you get a notion that there must be an absorption disorder when in reality there is no absorption disorder, it's just bacterial overgrowth. Similarly, delayed gastric emptying like gastroparesis also gives a false positive where you get low levels and you feel like there is an inadequate absorption from the GI tract, whereas the GI tract is just fine. That is termed as a false positive. Impaired glomerular filtration. Again, you'll be getting a low level of D-xylose in the urine, and you would assume that there is a problem with the GI absorption, but the GI absorption is just fine. So in these three cases, GI absorption is fine, but still you get a positive D-xylose, which means you get low levels in the urine and serum. That is the most high yield. You should know what a positive, what a negative means. Normal means normal means negative. You can just remember it by N. Normal means negative and abnormal means positive. And you should know what causes a false positive. So basically, it's just a test which figures out whether the mucosal lining is working adequately or not. And it helps you to differentiate between malabsorption due to certain causes. If it's celiac, it tells you that it's celiac. If it's just due to pancreatic enzyme insufficiency, it also helps you figure that out. So classic symptoms of they're talking here about celiac disease. Classic symptoms include abdominal pain, bloating, diarrhea, and weight loss. However, extraintestinal symptoms with no gastrointestinal features may also be the sole presentation. So the presentation can be variable. Dermatitis herpetiformis, that is a high yield one. It's a itchy rash on the extensor surfaces with papules and fluid-filled vesicles. So peripheral neuropathy is also seen in a lot of patients. Why? Because it's because of B12 deficiency. So you get like symptoms of subacute combined degeneration, and that is basically you hammer and bring down everything along with the onset of the symptom. Celiac disease, it's really unlikely that you get celiac disease in a patient who's 30 or 40. Usually it's going to be a child, it's going to be a pediatric population, and you would get a history of weight loss, you would get history of bloating, flatulence following meals, you're going to get history of diarrhea that is chronic in nature and that is leading to low growth. So that is how, and one of these high yield extra GS symptoms, and you just go for the, you'll also see anemia, you'll also see symptoms of a little bit of depression, and that's how you just take everything together and you diagnose celiac disease. So we have Whipple disease now. So the most easiest way to help you get the diagnosis of Whipple disease is the summary I've written. So basically, you'll get an adult who's like 30, 40 years old, and you would just feel like this patient has celiac disease. So, in simple words, symptoms of celiac disease in an adult, because you usually do not expect the symptoms, or you do not expect celiac disease in an adult. It's usually hypersensitivity or an autoimmune phenomena. So you catch it usually occurs early on in life when the person develops hypersensitivity to gluten. So developing it at the age of 30 or 40 is really unlikely. So you feel like the adult is having symptoms of celiac disease, and the biopsy shows biopsy of the GI tract shows PS positive globules in lamina propria. So this is the way you're gonna catch Whipple disease. You're gonna feel like the adult has symptoms of celiac disease like iron deficiency, anemia, chronic diarrhea, steatorrhea, malabsorption, weight loss, symptoms of depression, and you're gonna feel like it's celiac disease. But when you do biopsy, you see you see this finding in histopath, that is PAS positive globules in lamina propria. What do these PS positive globules indicate? These indicate the organism that is the Bacillus stropharima whipple. So this bacterium gathers in the lamina propria of the GI tract, and that forms a PS positive, that is periodic acid shift stain positive globules. So when you stain it, it gets positive staining because it has these organisms, these bacilli in the lamina propria. So it's most commonly seen in white men. Symptoms of celiac disease presents with weight loss, chronic diarrhea, steatorrhea, gastrointestinal symptoms similar to celiac disease, abdominal pain, diarrhea, malabsorption. So I just give you a really simple way to get the diagnosis in, and that is just adult developing celiac disease and the biopsy. They will give you the finding of biopsy because this is the one of the highest yield ways you can catch celiac, you can catch Whipple's disease. So yeah, we can also focus on other symptoms, but these are not the important ones, and the only way I caught it is through this. I felt like the adult has symptoms of celiac disease, and they always give you histopath, so you catch it really easily. Let's move on to lactose intolerance. It's a really simple one. Basically, acute gastroenteritis, viral gastroenteritis, or any disease can cause the brushing off or destruction of the lactase enzyme that is present in the small bowel, that is responsible for breaking down lactose and then absorbing. Lactose is basically a disaccharide, so that lactase enzyme breaks down this disaccharide into absorbable monosaccharides. So either due to infection like acute viral gastroenteritis, this enzyme can be lost, or due to congenital reason, like a person is born congenitally is born and has congenitally low levels of lactase enzymes. So it can be acquired lactose intolerance. Acquired, you'll see symptoms developing at the age of 8 9, followed after episode of acute viral gastroenteritis. Like, what is acute viral gastroenteritis? You'll get a patient, he'll just say that 1 month ago he had episodes of vomiting and diarrhea, abdominal pain, bloating, and a mild fever that lasted for 5 days after eating something from the outside, and then it went well. But after that episode of 5 to 6 days, he is having continuous bloating and diarrhea following meals. And once you inquire upon, he'll give you a history of dairy intake as well. So you assume that the viral gastroenteritis led to lactose intolerance due to brushing off of the lactase enzyme. So this is the acquired form. It can occur at any age, usually impedes, but it can also have seen in practice people at the age of 25-30 get lactose intolerance as well following an episode of acute viral gastroenteritis. So it can also be acquired where the person is congenitally born with low levels of lactase enzyme. So what are the symptoms? After dairy ingestion, lactose would not be broken down, so the bacteria would start digesting lactose in the GI, producing gas, and then you're gonna get flatulence, and the gas is gonna cause bloating. The gas is gonna cause pain because of bloating, and since the lactose is gonna exert an osmotic effect, it's gonna suck water from the GI tract and cause diarrhea as well. So you're gonna get bloating, you're gonna get pain, you're gonna get flatulence, you're gonna get diarrhea after dairy intake, specifically milk. So that's what we're gonna read. You're gonna get floating, you're gonna get flatulence, bloating, watery diarrhea. That's the primary one. Is the acquired one. Secondary one is followed by a disease 1 month or a few weeks after disease, usually after gastroenteritis. So resolution of symptoms, obviously once you stop eating lactose, you're gonna get well. Dietary restriction is the only way to get rid of the symptoms. And what is the way to confirm the diagnosis? When the bacteria digest lactose, they produce hydrogen gas. So the highest yield way to diagnose is lactose breath hydrogen test. So that is the way to make sure and quickly diagnose. A patient is having symptoms active, you just see the hydrogen breath test where you detect hydrogen from the breath. If it's positive, it means that the bacteria are breaking down lactose and the lactose has not been absorbed, and it's going to confirm the diagnosis. Another way that usually happens is ask the patient to quit dairy, and if the symptoms go away, it's confirmed that way. Hydrogen gas is what leads to bloating, abdominal cramps, and pain and flatulence. So lactose hydrogen breath test, it confirms it. And after resolution, if you stop the dairy intake and lactose products, if it goes away, that is also diagnostic. So that's it. Common causes of steatoria. So we're gonna just go